Hello, my name is Dr. David Keast. I'm at Parkwood Institute in London, Canada. And for the next few minutes, we're going to talk a little bit about chronic venous insufficiency and its relationship to lymphedema. First of all, I must inform you that there has been no financial support for this talk and there is no potential conflict of interest. So we've set the following objectives for the next few minutes. First of all, we want to look at the prevalence of chronic venous insufficiency in association with lymphedema. We want to take a look at the pathophysiology of chronic lower extremity edema, and then we want to discuss the key strategies for prevention and management of wounds related to chronic edema and venous stasis. So the problem of lower extremity ulcers is generally recognized that about 1 to 2% of the adult population have lower extremity ulcers in developed countries. It is stated in the literature that approximately 70% of these represent venous ulcers, but this is not the case in our clinical experience. The majority of our patients in our clinic have complex lower extremity edema, including lymphedema. The bad news about these lower extremity ulcers is that anywhere from 60 to 100% reoccur in the space of approximately 1 year. So if we look at data from our own wound clinic, this is data based on a database kept from 2006 to the present. It's a total of 3,367 patients. And when we sort out those with lower extremity ulcers or problems, we see that venous disease represents 22.5%, lymphedema represents 26%, diabetes with neuropathic diabetic foot ulcers approximately 18%, and about 5% were related to peripheral arterial disease. The remaining 30% are related to other etiologies and other areas of the body. So what is the prevalence of venous leg ulcers? Well, Canadian statistics obtained recently suggested that it was 1.8 per thousand over the age of 25. Recurrence rates based on a number of studies, as previously mentioned, is about 76% within 1 year. In 1998, there was a survey of U.S. family physicians who said that they saw approximately 1.5 patients per day with venous leg ulcers. Now, the problem with this particular study was that the results were somewhat questionable given the low response rate to the study. There is, however, a very good study from the United Kingdom which showed that nursing in the community are spending 30 to 50% of their time working with leg ulcers. And many were probably unrecognized venous and lymphedema. So what are the risk factors for developing a venous leg ulcer? Well, the first risk factor is being female, and unfortunately, if you're female, you have approximately twice the risk of developing a venous leg ulcer. Family history is important. If your mother had venous leg ulcers and your grandmother had venous leg ulcers, you're at much higher risk. If you have a history of a previous deep vein thrombosis, you are at risk. Obesity is a risk. Advanced age, probably related to mobility disorders, is also a risk factor. Pregnancy is a risk factor. The more pregnancies, the higher the risk, and it is likely that during the latter parts of pregnancy, the gravid uterus compresses the venous return and increases the risk of venous disease. Trauma in various forms can lead to venous obstruction. Reduced mobility certainly is absolutely critical, as we understand that the means of mobilizing fluid from the lower extremity is the calf muscle pump. And if the calf muscle pump has failed through poor mobility, you're at higher risk of venous disease. We also know that hip and knee replacements in and of themselves increase the risk of venous ulcers. Now, I realize this is an old study. It's from 1994, done by Tonny Phillips, but I still think it has an important message. And that was that 81% of the people with a venous leg ulcer had an adverse effect on their mobility. 56% said they spent up to 8 hours per week on providing care for their venous ulcer. And nearly Over 2/3 of these expressed a negative emotional impact, including social isolation, anger, and depression, and negative self-image based on having a venous leg ulcer. Essentially, if you have a smelly, drippy leg, it's likely that you're going to avoid social contact. So what is the cost? Well, we know that somewhere between 500,000 and 1 million Americans have a venous leg ulcer at any given time. And we may be able to extrapolate from some Canadian data, which was obtained in a 4-week study carried out by Harrison and her group in 2005, where they actually calculated the cost of providing care for 192 people receiving care for a venous leg ulcer. The interesting fact here is that $1 million was spent on nursing care and $260,000 for supplies. And the key message here is it's the labor cost, which is absolutely critical in the cost of providing care for people with venous leg ulcers. We know from the Canadian Lymphedema Framework's work to try and estimate the potential prevalence of lymphedema in Canada that the big gray triangle at the top is chronic edema related to venous disease. And here it was difficult to actually calculate the number of cases that we think that are related to this. So what are the conditions associated with secondary lymphedema? And the key thing is when you look at these, they start to look exactly like those that are related to people with a risk of venous stasis disease. Certainly the top risk factor for developing secondary lymphedema is a history of venous stasis disease. Second down the list is obesity. Lower down the list are things such as trauma and tissue damage, malignant disease and its treatment, history of an infection. So we have cases in our clinic where we've seen people who have developed a fungal cellulitis to their leg and end up with secondary lymphedema permanently. Chronic inflammatory conditions can also trigger secondary lymphedema. Endocrine disease, immobility, and dependency are absolutely key as well. And in our review of 326 patients in our clinic, we found that our patients with lymphedema had on average 7.3 comorbid conditions. So it really is a complex lower extremity chronic edema problem. Again, when we start to look at edema-related conditions in this 326 patients, you can see that 75% had a history of venous disease, 60% had a history of non-cancer related surgery, and only 10% a history of cancer-related surgery. 45% had a history of obesity. 20% had a history of trauma. We also recorded a history of lipedema, although the association with lipedema and chronic edema is somewhat controversial at this time. Immobility related 3% of the diagnostic codes that we found, and infection only 0.3%. Other edema-causing conditions represented 29%, such as congestive heart failure, chronic kidney disease, and liver disease. Just a diagram to remind you of the intimate relationship between the capillary bed, seeing the arterial in red and the venous side in blue, and the capillary bed in the green on this. We know that approximately 16 to 18 liters of fluid filters out of the capillary bed per day. We previously thought, based on Starling's law, that filtration primarily occurred on the arterial side and reabsorption occurred on the venous side. But we now know that filtration and reabsorption occur throughout the capillary bed. And we also know that filtration is always greater than reabsorption by the capillary bed. So thus 100% of all excess tissue fluid is handled by lymphatic transport. So tissue fluid dynamics look somewhat like this. If we have a normal filtration where the absorption and lymphatic transport are equal, then we do not end up with chronic edema. We can, however, end up with high output failure, and this is where filtration is greater than the ability of the capillary bed to absorb and greater than the capacity of the lymphatic transport system. This is seen in venous disease and in volume overload conditions such as congestive failure. Low output failure, on the other hand, has normal filtration, but absorption and/or lymphatic transport are reduced. This is seen in lymphatic obstruction or dysfunction, immobility, and inflammation. So how do we end up with skin breakdown if we have this chronic edema? Well, chronic edema actually separates tissue cells one from the other. This leads to reduced oxygen transport from the capillaries to the cells in the tissue. With reduced oxygen transport, the only response that the cells can undertake is an inflammatory response. So we then end up with a tissue that is both inflamed and somewhat hypoxic. The result of this is that minor trauma will often lead to tissue breakdown, and once the tissue does break down, it is very difficult to close, largely because growth factors don't migrate well to where they are needed, and we have a high level of inflammatory cytokines in these particular tissues. One of the most common ways in which a venous leg ulcer happens is that if you have chronic edema, the leg is often quite itchy. And we find that often what happens is unknown to people, often when they are sleeping, they will scratch their ankles with their big toe and lead to breakdown of the tissue. So how do we go about preventing complications from this? Well, there are some strategies, and one of the key parts of this is education of patients and caregivers. Key to prevention is compression therapy, and compression therapy for life. And we need to help them arrange for proper fitting of compression garments and for funding where possible. We need to educate them about proper skin care. If the skin is well cared for, it is less likely to break down. And exercise is absolutely key in helping tissue fluid mobilization. We need to look at the barriers to and the facilitators for self-care. In today's environment, with resources stretched quite severely, self-care has become an important aspect of care and prevention. We need to provide written instructions. A visit to the clinic can be somewhat overwhelming, and if you provide them with written material that they can refer back to, it will help them to implement those strategies. We need to review compression garment care, because it's critical that they understand that if they are compression stockings, that washing is not because they're necessarily dirty, but it resets the elastic. And we need to arrange for regular preventative follow-up. Luckily, in our particular clinic, we've had a very low recurrence rate of venous leg ulcers, because largely we have seen up till now venous leg ulcer patients once a year to remind them of their appropriate preventative care and ensure that they have up-to-date compression garments. And we need to advocate for system recognition and support and funding for this. So I hope in these few 15 minutes that we've talked a bit about the prevalence of chronic venous insufficiency and its association with lymphedema. We've looked at the mechanism whereby skin breakdown can occur, and we've discussed some key strategies for prevention. Thank you. We will discuss this at a question period at the end.
My name is Tonny Karlsmark. I am a dermatologist at the Department of Dermatovenerology and Copenhagen Wound Healing Center in Copenhagen. My disclosure, as you can see. Legs, those legs. All the world's accidents are gathered in the legs. As you can see on the figure, the most frequent site of chronic edema is in the leg. The same is with chronic wounds and cellulitis, where you have 70 to 80% of the cases. A classical wound, a venous wound with granulating tissue, but also with a huge amount of pigment, hemosiderin. What is the pathophysiology of the venous leg ulcer? If you have a normal and well-functioning venous system, you can reduce the pressure in a vein on the foot to about 10 millimeters mercury. As you can see on this figure down here, when you're resting, the pressure is about 19 millimeters mercury. But when you're moving, for example, walking, you're able to diminish the amount of pressure to about 10 millimeters mercury. When you are resting again, the pressure is rising. But in people with chronic venous insufficiency, the vein pressure is much higher, often 40 to 50 millimeters, as you can see on the same figure here, where you can see the person are not able to diminish the pressure to more than 60 millimeters mercury. This high venous pressure gives a greater leakage from the capillaries and thus edema, as you can see here. If the vein pressure constantly is above 40 millimeters mercury, we know that venous leg ulcers develop. Then, why do chronic edema induce ulcers? We know there is a leakage of liquid, macromolecules, and erythrocytes. But the high pressure also gives an entrapment of the leukocytes in the capillaries, this producing a local inflammation and later on fibrosis. We call it lipodermatosclerosis. So the edema, as you have over here, produce a local nutritional deficiency, but also tissue hypoxia. The inflammation, together with the other two, produce the wounds. If you look at the late stage of chronic edema due to venous insufficiency, you will remark that there is a huge amount of pigment on the leg, but also that the shape of the leg is like a reverse champagne bottle. And this is due to the lipodermatosclerosis. How can we reduce the venous pressure and avoid edema and wound development? We could do it using compression, but also exercise with compression, because compression is essential. Another thing is that we could have help from a physiotherapy to improve exercise. So, if you have an edema, compression is here to fight for you. Then, compression for the prevention and treatment of wounds. What about that? We actually know that from the library, from the Cochrane Library, that prevention is a benefit. And even that treatment, that you have a faster healing rate using multi-component bandages, that is better than single bandages. And also that you have a faster wound healing, you have less pain, and you have improved quality of life using compression. So it's the winner all over. What about wounds in chronic leg edema? We know that if you have a well-controlled edema, you will have a lower amount of wounds in the leg. But only 43% of those with wounds have well-controlled edema, so something to come. Then, showing the treatment, as you can see, it is important to use the compression bandage. You can use elevation also. It is important to activate the muscle pump, lowering the venous pressure. And treatment of wound environment is also important. And the recurrence prophylaxis, that is compression stocking, may be also venous surgery, but only on the superficial things. What is the mechanism of the compression? It is to prevent edema through increased tissue pressure, to prevent capillary leakage of blood components to the surrounding skin, and to support the muscle pump via a new fascia. It makes the vein more competent and it reduces the reflux, also reducing the venous diameter. You can different kinds of compression bandages. You have what you call very elastic bandages and inelastic bandages. As you can see, where it's possible with the elastic bandage to stress it more than 100%. You cannot do that with the inelastic compression. But, as told before, we used now, as a much better treatment, the multi-component bandages. It can be used 3 or 4 bandages, but it also can have 2 compression bandages in one treatment. Another thing is to use compression stockings. The compression stockings can be in different with different pressure, depending on what class you choose. The pressure on these classes is different from country to country, but class 1 is the lowest pressure. Normally we use the class 2 stockings, but you can even use class 3 and 4, but it is more seldom at the moment. You use flat knitted because flat knitted stockings, it is with a better fit, but you can also use round knitted stockings where they are knitted like a cylinder. There are some relative contraindications. It is if you have a very low ankle-branchial index, or if you have lymphedema or wounds, and severe neuropathy. What about the wound care? We like to have healing of the ulcer. How can we do that? We can reduce the edema using compression. If there is a moment of ischemia, we could hopefully revascularize the leg. If there's an infection and necrosis in the ulcer, it is very important to remove the infection and the necrosis using debridement. You can use local antiseptics or systemic antibiotics. And if there is some neuropathy, it is very important to offload the pressure. So removing all frequently triggering causes for healing. If you look at the wound treatment in general, there is a treatment of the wound bed, that is removing of necrosis and fibrin, using frequent debridement. You can use rinsing with tap water. Moist wound healing is efficient. And you can also use neutral and non-adherent wound bandages in general, but even active wound bandages in cases of infection, for example, silver. The wound edge is also very important. It is important to prevent maceration. You can use zinc paste, you can use silicone oil in order to protect the wound edge. And then, of course, the wound surroundings. It is important, as we have told before, to reduce the edema. You can use using a circular bandage. If there is an eczematous reaction in the area, it's important to minimize it using local steroid. You can also use zinc stockings, tar paste, and even red bath calcium permanganate. So good skin care is important. Look at this picture where you have an area of maceration around a wound a venous wound. Prophylaxis is very important here. That is due to prophylaxis against the wound fluid. And here you can use zinc paste, you can use silicone oil. That is very efficient in this treatment. If you have a patient with an eczematous reaction, as you can see here, steroid ointment and tar could be used. Tar, for example, like ectopaste. So, a final overview. What is characteristic of the venous leg ulcer? It is irregular, it's surrounding wounds, superficial wounds, often solitary and not painful. Rarely with necrosis, often with a huge amount of wound fluid. You also have eczema, edema, hyperpigmentation, lipodermatosclerosis, atrophia blanche, and if you have any pain, it normally fades by elevation. The location is always on the lower leg, most often around the medial malleus. As you can see on this classical venous leg ulcer, where you have a granulating tissue. Here, also with hyperpigmentation in the area. A case with lipodermatosclerosis and hyperpigmentation in the gaiter area. And a patient with a huge amount of eczema due to the wound fluid, or maybe also from the treatment we have applied. There is a huge amount of edema, and it is very important to remove the edema. Another example of eczema where you have to use steroid ointment and maybe tar treatment like ectopaste. So the etiology for the venous leg ulcer is the venous insufficiency. It can be due to the deep venous thrombosis or familial. It can be reduced mobility, overweight, standing work, trauma, on temporary surgery on legs, for example, alopecia. The diagnosis is primarily to show that you have a venous reflux using a venous scan like duplex scanning. The general treatment is compression, is elevation, is activating of the muscle pump, and recording prophylaxis, use compression stockings, maybe, if possible, venous surgery. Then, thank you for your attention. That is Bispebjerg in the spring.